primarily. Of course, if there's a trauma position or trauma situations, we may have to do it with the receptor itself, but primarily, log down. Primarily, we're going to want to do these with our puppy.
Which view was this again? What are you talking about?
So we're looking at the humerus now.
The shoulders, you just basically looking like the shoulder, like right here. The humerus, you look at the humerus.
So humerus was on the last chapter.
Like, yeah, the shoulder, you gonna be looking at just mostly like this, including the clavicle and the, yeah. So it's gonna get that area. So we're going backwards.
Yeah, so humerus is in your previous chapter, guys. Remember that?
Oh, I see. Oh, it's in this.
Yeah, it's in the first chapter.
All right, so first one we're going to go over is the AP humerus. Patient is going to be primarily standing. Of course, they can be seated or supine depending on patient condition. We're going to place the top of our border or our light field about 1.5 inches above the humeral head. Slightly abduct the arm away from the body and have the hand supinated. And our coronal plane is going to be passing through the humeral epicondyle, or sorry, it's going to be passing through the, is that right? Yeah, passing through the humeral epicondyles, which should be placed parallel to the IR.
So once again, remember those epicondyles, guys. Which one's going to be parallel, which one's going to be perpendicular. So similar to what we've already talked about with the shoulder, the elbow, so on and so forth. And did you guys learn to turn your tube like you see in that picture in the lab? Turn diagonal like that? It's going to save you a lot of headache on that x-ray because the humerus can be quite long depending on the person. And when you turn it diagonal like that, it's going to give you a much better chance of getting it all in one shot. Because you're just following the shape of that arm better. It is great to, like the lady in that picture, move your arm out like that, abduct it outward. You'll see some people that put the arms resting by their side, but you risk having too much overlap with the torso that way. You want to isolate that humerus, move it out of the way, just like Anthony's demonstrating there.
And sometimes you might even like kind of turn them a little bit, just if you want to like reduce that OID, like just slightly. Central ray, we're going to be perpendicular to the mid portion of the humerus, so right in the middle of that long bone. Once again, our collimation field, our light, is going to be about 2 inches distal to the elbow joint. And we're going to want to be about 1.5 inches, 2 inches superior above the shoulder. And about 1 inch from each side. Suspended respiration on this one. Just don't move, don't breathe. Yes.
What plane would you say that is? Like MCP of the humerus or the?
Good question. What plane of the humerus?
Not considering that this is like, you know, given that this is like anatomic position, I feel like, does it even have a plane?
Not particularly, yeah.
That's more so going to be for your torso. I go back a second because I got a great question for you guys. How is the hand positioned for the humerus?
Supine.
Correct. The hand is supinated. Hand is supinated. Even though we're not looking at the hand, we're going to supinate the hand for the humerus. And what's the purpose of that? To place the epicondyles parallel the IR.
So not like that image, right? The one on top.
The one on top, she's kind of a little limp. It's as long as her epicondyles are parallel, it'd be okay. But ideally, yeah, you want to make sure it's. You don't want them giving you like a limp, like a handshake limp.
Wait, so is it like this?
So it can be like this?
Because isn't
long
this
as they're-
supinate?
As long as we have our epicondyles parallel. Some people it may be different. Like I know some people they'll a little bit too much, a little bit less. But as long as the most important thing is having those epicondyles parallel to the IR. Hand positioning may be a bit different depending on the person. But no further tests. And it is super. Evaluation criteria here, we're going to want both our elbow and shoulder joints included here, which is why we leave our lie a little bit open past the elbow joint there to make sure we include it. Femoral epicondyles are without rotation, we want to make sure they are parallel. Femoral head and the greater tubercle are in profile. Why would the greater tubercle be in profile for this?
It's supinated, like rotation.
Because it's supinated, we have external rotation on this. Outline of the lesser tubercle, therefore, would be superimposed upon the femoral head. And like pretty much all of these other projections, we're going to want good detail on the bony trabeculae and the surrounding soft tissues. So that's going to be like the striations, like the details, the lines of the bone. This is a pretty low quality image, so you're probably not going to really see it on this. We may see some on a couple other images that are coming up. That's just going to give you guys a little heads up when you guys do, what's the name of the class? Image evaluation. You're going to have to figure out, is this an optimal image? Can we see details like that? So it's just a little bit of vocab thrown in there just to kind of get you guys ready for that class. So let's see. A little bit of anatomy here. Of course, we have our acromion. You can see that greater tubercle is in profile on this. Medial epicondyle, lateral epicondyles. Let's see. Of course, we have our humerus, which is the star of the show here. And then, just to make sure we didn't forget, what's that joint right there where the humeral head is sitting?
The scaphoid
Humeral joint. And if we're looking for the landmark, what are we looking for? Glenoid cavity, glenoid fossa. Very good. Moving on, we're going to go into the lateral humerus here. Now, we have two lateral humeruses. One with without trauma, non-trauma, and then one with trauma. The one we're looking at here is going to be the non-trauma. Similar light field, similar collimation, about 1.5 inches above the humeral head, above that shoulder. Make sure we get that joint. And if possible, internally rotate the humerus, internally rotate the hand and the humerus so that we can have our epicondyles are going to be perpendicular to the IR. Internally rotate, flex the elbow. We're going to have that back of the hand on the hip. And again, we're doing that to make sure the epicondyles are going to be perpendicular to the IR. You don't remember doing this a lot?
Yeah, but it wasn't like that bent. I think we had a barely, like a chicken wing when we do the chest. That's what he told us.
So chicken wing position.
Not hard. I don't know what y'all would do. Did y'all do that?
Yeah, last week. I remember last week.
He said he don't remember last week.
Yeah, I remember
Last week.
Y'all have, y'all
that. I know
y'all
we
be
did
having
this, and then,
I think she just
What else
did
did we do?
this.
Yeah,
Huh?
maybe
I
that
think
just
she
did that.
didn't make us go.
oh, we just did this.
Oh,
We
just
put it up
internally
here.
rotated?
Like
Yeah,
an
we just
internal,
did it
external shoulder.
So yeah,
We just
as
did an external, internal,
again, like the
and
like on the
scapular one.
like on the AP, as long as those humeral epicondyles, as long as those humeral epicondyles are perpendicular, you'll be getting proper positioning on this.
Cause it's the same thing. For humerus, but like I said, they ain't.
So since we're rotating the hand internally on this one, can anybody tell me what we can expect? Well, lesser tubercle is going to be in profile. Correct.
It's like an internal, external.
Patient positioning on this, patient is actually going to be facing the IR for this. I know in the previous one they were AP, but you'll also see them do this way as well for the lateral humerus.
So this picture is a trauma.
This picture
No.
here,
Since it says trauma next to it.
I don't think this is the trauma position.
Yeah.
Oh,
Patient may hold injured fracture on.
yes. So, yeah, that's right.
Okay.
Sorry, guys.
That's
So
okay.
primarily the patient is going to be facing the IR for the trauma position. Reason they're going to be doing that, of course they're not going to be able to really move their arm. So what they'll do, they'll usually have it like this close to their body. So they'll be supporting it with their uninjured arm. So that's why we'll be doing it this way. So having them face the IR, similar light field situation going on, but the important thing is that we're not really going to be rotating the arm or anything.
Was the last one an Althea?
The last one?
Right?
Last one was no RPO or anything, it's just a straight AP position. So this is our trauma position here. We're gonna align the humerus into a medial lateral projection. Go back. So this is our non-trauma position, which is gonna be in an AP. It's essentially the same thing, just turning the patient the other way around.
Cause like I say, they're holding their arm, so there's too much pain.
There's no
No,
oblique.
the next one.
Oh, the next one?
The trauma position, but it's close to them.
This
That's the
is gonna
trauma
be the
position?
trauma position here. There's no obliquity on this. This is just from a PA position.
Oh, it's a cute position.
Because it's still lateral.
Lateral to
Like
humerus.
if you're looking at it, AP,
As you can see, our epicondyles are still going to be perpendicular. So that's going to be indication that we're looking at a lateral humerus. We're just turning the patient the other way.
still got it. One sec.
Yeah, we're still looking at the side of it. Again, it's just those epicondyles are just looking at the back.
That's it.
So this is what that would look like here. Elbow joint is visible, shoulder joint is visible. Superimpose humeral epicondyle.
That's for both, right? Trauma and non-trauma.
For trauma and non-trauma, yes. So we have our humeral epicondyles perpendicular to the IR. Ideally, they are going to be in this superimposed position. And like we said earlier, with the hand being internally rotated, that's going to place our lesser tubercle in profile. Greater tubercle is going to be superimposed on the humeral head. Do we feel comfortable with the difference between the trauma and non-trauma position? Okay. Just, I know I hope I didn't butcher that for you guys. Yes.
You probably have already talked about it, but what is beam divergence?
Beam divergence. Can you see that?
Slightly distorted to beam divergence?
Ah, yeah. Slightly distorts due to beam divergence. So that's actually something that Mr. Fong would bring up in PRE. But beam divergence, essentially, as the beam shoots out, it doesn't go in a straight line. It actually goes like that. So it goes out. So that property of it going out at an angle is called its beam divergence. So you have some of the X-rays going straight, some of them going at angles.
Is that from the mirror?
Hmm?
Or the,
So that'll be from as they shoot out, as they hit the mirror,
okay.
it'll diverge the beam. But you guys will go over that more so in PRE. Alright. So
Last few slides.
last few slides should be going over a couple of images. So what is the projection and the anatomy of interest that we're looking at? Hearing AP clavicle, axial clavicle, AC joint.
I'm gonna roll with B.
We're gonna go with B, AP axial. Okay. Any other answers?
Look very closely. This is a bit of a trick question.
Okay. Hearing AC joints. Nobody going with D?
It's definitely D.
I can't even process what D is.
So it is the AC joint.
This one.
Does anybody know why?
I would have thought both AC joints would have been on them. That's why I didn't say
Typically,
AC.
yes. When you go over a unilateral AC joint, which is not really ever done, but there's one aspect that tells you that's the AC joint versus, what is that? How open that joint is, yes.
What does it
The
say?
joint is wide open, which tells us that they are holding a weight.
Yeah, so usually they won't be that.
So that's a bit of a mean question, I'm sorry. I want y'all to look closely at the details. Look closely at the details.
Sorry.
You gotta develop that eye for detail, guys.
Yes, that space there. Normally that space won't be so open. It'll be a bit more closed off. But that is an indication that there's weights.
Now, I won't be that mean on your test, I'm just gonna say, but I just want to see if y'all could pick up a little detail there.
Alright, so what are we looking at here? What's the projection? What's the anatomy? Lateral scapula, shoulders.
I'm gonna roll with A.
A lateral scapula.
I'm hearing a lot of A, lateral scapula. That is correct.
So why is A the correct answer?
The humerus is pulled out of the way. You can see the lateral.
Something lateral, really good profile.
Yeah, look at that humerus, how much is moved out of the way. How's that patient positioned? What are they doing in that X-ray?
The hand over
Opposite
the
shoulder,
chest.
correct, to isolate that scapula. So we know it can't be B, which makes sense because it won't be by the side. Letter C looks totally different. What's letter D done for?
That's for the,
Like a RPO, LPO.
And what's it done for though?
Why
to
do
see
you?
the
Glenoid
See
cavity.
open what?
the
Limb
open
joint.
Scapulohumeral joint space, correct.
Alright, what about this one? What are we thinking? What do we see here?
That's a great question.
I'm gonna roll with B.
It's not C.
I'm gonna roll with B.
I'm hearing a lot of
Be
B.
really quiet.
B.
Speak up, don't be afraid to get it wrong.
Oh,
B.
you just say B is in boy.
That is B.
Now, why is B correct, guys? Because what if I had, like an external and internal position on there as well?
You said you weren't gonna do that to us. You wanna do that.
Well, for these, yes, because I need y'all to understand neutral, external, and internal. It's a very important aspect, so.
see the humeral head, you don't see the tubercles.
Correct, say the louder, Monsi, what you said was exactly
For
right.
the neutral position, you see the humeral head, but not the tubercles in below.
Correct. Correct. You gotta learn to identify those visually, guys. I think there's gonna be some more in these with the questions to review that. That's another really good
Oh
one.
yeah, this is a really good one.
Oh, that's C.
C.
That is C.
What piece of anatomy is in profile on this image? It's unique on this
It's a
one.
joint. The glenoid.
It's at the top
No.
of that humerus.
Oh, the lesser.
Oh, the lesson.
That's our lesser tubercle. Remember, on this one in particular, that's the lesser tubercle that we're seeing in profile. It looks different than the other ones. But this one only shows that lesser tubercle. It does look like a greater, that's why I wanna make sure y'all know. It can be
It's a
tricky.
lesser.
Oh, the angle.
Cause you should see the
Triangle, that's the coracoid. It just looks a little shaky a little bit from that patient. Nice triangle though. Nice
Is the one
isosceles
that-
triangle there. I don't know if
It's
it's
a
quite
coracoid now.
isosceles,
So
but.
we have our coracoid. Anybody know what this would be here?
That's the crest.
The
That's
cone?
the
Single
spine.
pose, guys, what is that? He's pointing at.
It's not the crest.
The
A
cone.
Chromium,
It's chromium.
very good.
Yeah. So you'll see part of that, and then the rest of it being
It's connected to
superimposed.
the clavicle closer to the.
Yep. So what was that again? I think I heard it. Clavicle. All right. What are we looking at here?
D is in dog.
Here's a dog. I'm here. AC scapula. I'm here. Gray sheet.
Look at what your arm's doing, look at your anatomy, look at your centering.
I'm still gonna say D is in dog. I could be wrong.
And here D. D. There it is. All right. So it is an AP scapula. We see that our arm is going out, so that's an indication that we're at a 90-degree angle. I was hearing a lot of gray sheet, but remember, guys, what is that gray sheet used for? To see the glenoid cavity. We want to see that glenoid cavity free of any superimposition. We want to make sure it's open. So we kind of see it here, but we want a nice, clear, dark space between that humeral head and the cavity itself. So AP scapula and our stop sign position.
Can you go back to that one?
Yeah.
That's exactly right.
See? Yeah.
So here's our
It's flat
scapula.
there.
That's really that.
That's exactly
They're like a
it's the
nice
same
size.
stuff that I do. That's why I do
What was
that.
that?
Association.
So let's go ahead and just review this one a little bit more, guys.
It helps.
What's this up here? Chromium. What's this? Coracoid. What's our joint? This right here. It's the lateral border of the scapula. This down here. Inferior angle. This medial border. Okay. What's our joint here?
AC joint.
Okay. What's our landmark?
Very good.
Isn't that a
Second.
good coach now?
That's not a good picture.
That's not a good picture.
Like, the scapula, you can barely see it.
That's,
Yeah, because I kept looking at the glenoid cavity, it's more visible than the scapula.
that's gonna be pretty typical of your scapula. They're not the prettiest x-rays. It's hard to see that through the torso. I don't know if I have a gray sheet on this set of questions, but we'll go back to the gray sheet because I wanna make sure y'all know the difference between the gray sheet and the scapula.
You don't want to go back.
Let's see, I don't know if I have it on this, let's see if I have it on the questions, but if not, we'll go back.
You want to just keep going one by one?
I keep going for now.
Keep going for now? Alright. Okay, so what are we looking at here?
Ooh.
We got AP shoulder, AP clavicle.
That's A.
Neutral, external, internal,
That was a little hard to
I
see.
think it's A, but they're like.
That one is a little hard. So I'm hearing A, but they're
It look like it's
dislocated.
just too much internal.
What do you think it is?
That's a fucking picture.
Mhm.
I think this is a bad picture.
Oh,
isn't it?
wait, no.
It is.
But if you
If
did
you
take
can't,
clothes on
it
there,
could
say,
be.
I did, I'm
I
sorry.
could do.
See.
I got
Is
jumped
that-
a little bit.
If you
It
can't,
is.
it
Wow,
could
very good, very good.
be. If you can't do anything, that's showing.
So,
Did
the
they
reason
say-
that's AP clavicle, guys, is because, well, first off, the centering. Look at your coracoid process. You're supposed to get an inch below the coracoid process. Look how far lateral the coracoid is. Look how you can see the entirety of the clavicle centered in the film. That was the indicator right there. We know it's a very ugly picture. And typically though, and you know, when I'm being less mean, it'll be far further gone. I'm sorry. I want y'all to develop your detail eyes, guys, here. It's very important that you learn to develop these eyes to differentiate between these exams. Not because Mr. Donahue wants to be mean, because the registry is going to ask you to do the same as we develop our x-ray eyes. But the indicator there, guys, the entirety of that clavicle is seen from both ends. And we can't even make out the tubercles and humerus anyway, if you look closely on
So
that.
that's not the greater on the lateral side?
So if you see like this one, for example, that sternal end is being cut off. And you can see we're more centered to the coracoid here, like it's right in the middle. But if we look at this one here, that coracoid's thrown off, we're centered above it. We never center above for shoulder or for scapula, we're always below the coracoid. And again, we can see that sternal end of the clavicle there. So that's an indication that, okay, this is probably a clavicle, what we're looking at.
And if that was an AP axial, you would see that clavicle thrown up even further, it'd be a greater space between the clavicle and the scapula, and it'd be a lot more horizontal in shape.
I thought you were gonna say.
Here we go. Here we go, guys. This is what I was hoping was on there. I thought it was on there.
Oh, V is a boy.
B is boy, that is gonna be our gray sheet.
Now can y'all see why that's the gray sheet versus that scapula we looked at earlier?
Yeah, there's more negative space there, there's black space there indicating that the joint is open.
And it's collimated like to that area.
And it is collimated to that area, correct.
So for a gray sheet, you're really not even gonna see any scapula at all. And you'll see that humerus clearly horizontal as well on your scapula. So gray sheet, we're not really gonna do anything on at all. So rest to the side, put the patient in an oblique position.
What oblique do we put the patient for gray sheet?
RPO, RPO.
RPO.
There's another great practice. What was that, guys?
B is in boy.
External rotation.
Now,
That
that
is,
was being very nice, because there's a nice arrow pointing at that tubercle for you. Please do not expect your test to have arrows like that. But it's just making sure, I want you to train your eyes and look for those tubercles, guys.
You wouldn't be mean and put an irrelevant arrow, like towards where the lesser tubercle could be?
No, Jay,
actually,
no.
he's done that before.
Okay, I
actually. That's
figured
happened.
that
Yeah.
it seems on
When
brand
you're at
for
senior,
him.
when you're at senior level, I'll get more mean like that.
Okay.
We were still juniors. So, yes, external rotation on this. What's our hand position?
Supinated.
Supinated, yeah, supinated. And where would
Where
our
are the epicondyles doing?
Parallel.
parallel there? All right. What anatomy is labeled at the arrow? Greater tubercle.
Remember, guys, the greater tubercle will always be on the lateral side. The lesser will always be on the medial side of the shoulders. So whichever one you can clearly see is your indicator of which position their arm is in.
Is the trabecular detail there indicative of the lesser tubercle or the bicipital groove?
You're seeing the groove there.
That's that line?
Down line right there. Yeah.
Okay, cool. So then the lesser tubercle is off to the left of that just a bit?
Correct.
Yep.
Superimpose on the femoral head.
Can't really make it out here.
Ooh, that's a great one
It's a good
there.
image. What do you guys guys thinking here?
D is in dog.
Lead shoulder. Okay. Is that what we're all thinking, D?
Yeah.
Are you sure?
Mhm.
Yeah. Why's
Yeah.
not A?
I looked at the marker.
The scapula's lateral.
I looked at the
I
Y.
looked at the marker.
I looked at the wall.
But the lateral scapula shows a Y too. Why is it
It's
A?
because the humerus would
But it
be
looks kind of different.
look busy.
The humerus is superimposed, which is why it's the PA oblique shoulder Y. We can also call it trauma Y. Keep in mind, trauma Y. It's a trauma view.
Yep.
Checking for, what do we do that X-ray primarily for? What are we checking for?
What about the humerus?
Dislocation.
Dislocations of the humerus.
We're not really concerned with the scapula in this view. In fact, we're not at all. It's done primarily to check for dislocation of the humerus.
Alright. What about this one here?
Yes, that's a great.
D is in
Very.
A, here in B. Melanie, what do you think it is? A.
See the lesson you
You were
It's
seeing
the
lesser
opposite of
tubercle.
patient.
So he's kind of unsure on this.
I'm going with-
Yeah, that is A. It is the internal position.
Point out that lesser tubercle for him, Anthony.
So that's gonna be right there. Lesser tubercle right there. Remember the greater tubercle we were able to make out, but we're not able to make it out here. But we are able to see that lesser tubercle on the medial portion. Did everybody see that? And then how would the humeral epicondyles be positioned for this? Perpendicular, which means our hand is in what position?
From
Internal rotation.
Can you go to the neutral position on here, real quick?
There you go.
Oh, is this one?
This is where
It's much more round, the
Yeah.
humeral head is.
it's a lot more smooth. It's a lot more smooth on that one, and then our external, you can make that out. It's not as smooth anymore. You can make out that protrusion here, given that bigger tubercle. And then on this one here, that protrusion is gone. It's superimposed, and we're able to see the protrusion on the medial end here, which would be that lesser tubercle.
And when you can see it, look to the groove. You see the groove on that one as well?
Mm-hmm.
Look at the position of the groove. See how the groove there is more medial? Go back to external.
External is kind of.
Just slide forward.
See how the groove is more lateral now?
Mm-hmm.
And then of course the neutral, you don't see it at all.
Okay, so here we are. Hopefully nobody saw the
D is in boy.
These are boys.
Yeah.
What can we see here on this?
The spine.
We can see part of the spine. What else can we see?
The ribs
Clap.
are, the ribs are blurred out.
The ribs are blurred out.
Transthoracic, and the clue's in the word there, guys. Transthoracic, through the chest, through thorax. You're seeing, spine and lung with a humerus, and it can only be one thing, transthoracic. That's their trauma view.
Like Shaheen said, those ribs are being blurred out. They're still there. They're still. You can kind of make them out, but they're being blurred out. And what do we use to blur out those ribs?
Just the
No, ma'am.
What was that?
Orthos.
Oh, the breathing slow.
That slow breathing, that orthostatic breathing.
X-ray.
Run it down.
Yeah, that's right. X-ray.
That's it, guys. That's the end of that chapter.
That's it.
Maybe do another one.